Thank you very much. I am delighted to be here to give this talk about palliative care choices, particularly targeted at those people who either have mesothelioma and lung cancer or who are friends and families of patients with that disease. I'm a medical oncologist by background, and what I hope to do in this talk is to really paint with a broad brush the role that palliative care should play in the care of patients with mesothelioma and lung cancer. This is the main message that I want to get across, that palliative care is a part of the treatment of patients with mesothelioma and lung cancer. And the way I'd like to outline this talk is first define what I mean when I say palliative care, then describe the evolution, the physician role, and then finish up with some of the new challenges and really how this is pertinent to patients. So let's start first with what is palliative care. And I think in a talk like this, it's always nice to begin with a real patient. So this is Frank. Frank sitting at a dinner meeting, not unlike the one that we're sitting at right now. He's sitting there with his son. He's a 58-year-old man, so I would call that quite young. He has a fever and a cough. And the fever and the cough, and he had a bit of chest pain, and it was bad enough that he went to the emergency department because it wasn't getting better. And the evaluation showed he had pneumonia, and so he was admitted to the hospital. But as you can see on this film, as he was being treated, if you notice here, this is his heart, and here are the ribs, and these black areas here are the lung fields. But there is a mass here that doesn't belong here. And because he had aches and pains that were a little more than what is conventionally associated with having a pneumonia, he had a bone scan. And you can see on this film, and you can see with the red arrows here, there are black parts here on the back of Frank's skull that really shouldn't be here. And if you notice here on his skeleton, there are also asymmetric black spots. So Frank's sputum sample came back with lung cancer. Now this is actually a pretty conventional way that this diagnosis is made. For many people with mesothelioma, it's a very similar story. There's pain, there is a person doesn't feel well, and this kind of diagnosis gets made. Now I want you to think with me. So what's going through Frank's mind now? Because Frank will be told, he was told about this diagnosis. When you think about it, well, Frank most of all was worried, right? Patients who have a diagnosis of cancer, and particularly a diagnosis like mesothelioma or lung cancer, the first is frightened. Frightened. Will I suffer? Will I have terrible pain? One of the most important things I want to get across here is that for most people, their fears and their fantasies and worries are driven perhaps by experiences or stories, but most often by media dramatizations. When you think about what serious illness is like on television, it tends to be dramatic, it tends to be extreme. Too many people think that is what will happen to them, and it simply doesn't need to be true. It is true that patients with advanced cancer and with diseases like mesothelioma do have symptoms. This data from a representative sample of seriously ill patients across the country showed 3/4 had shortness of breath, about half had pain. So Frank's concern that he will have symptoms is well-founded. What Frank also needs to know is there are ways to control this. There are ways to keep these symptoms under control, but first of all, you need to make sure that the doctor knows about these symptoms. But it's more than just physical suffering, isn't it, that Frank is worried about, or that you might be worried about. It's the psychological distress, anxiety, depression, worry, fear. All of these are part of the cancer experience. In one national study, 40% of people with cancer worry about being a burden on their family. Well, this is clearly not in the physical domain, this is in the emotional, psychological domain, and it's every bit as important as the physical dimension. Well, what about the social dimension? What about the family structure? What about support? Frank lived only with his wife. His children were grown and gone, living in other cities. He didn't have other friends or family around that were really close. I think this is one of the challenges that is probably uniquely American, in that when people are seriously ill, there isn't a large group that easily gathers around. And yet this sense of needing to feel connected is important. I think that's one of the roles that mesocare plays, is having that sense of connection. And yet, interestingly, when Americans are surveyed, 98% have full confidence in their doctor to meet all their needs, physical, emotional, social, even spiritual. And there's no difference between whether patients are in managed care or in standard private practice medicine. Now, I want to paint a picture then. If we think about all the care that Frank were to receive for his cancer care, in this diagram, if it's a red box, where here is Frank's presentation at the emergency department. For many patients, and certainly this is the way I was trained as an oncologist, across time here it was about fighting the cancer. Come on, Frank, we got to fight this cancer. We can beat this. Come on, Frank. Oh, keep on going. Keep up your hope. Keep up. Oh, we lost one. I hope it strikes you that, gee, that seems like a very incomplete approach to conventional cancer care. And so we developed the idea of comfort care that I've shown in this yellow box. Comfort care at the end of life, when the approach is no longer to treat the cancer, but we need to just relieve the suffering associated with the cancer. And we developed the hospice Medicare benefit, requiring a 6-month prognosis. And clearly, and this takes care of patients and families, including bereavement care after a patient has passed. But if you notice, there's a problem with this. Although this is better than just treating the cancer and not the whole patient, if you notice, there is a sharp discontinuity. You're either in anti-cancer treatment land or you're in the land of symptom control only and hospice care. This is where I work in part, at San Diego Hospice. Many hospices were founded and developed in this notion that hospice care is about the time when only focusing on comfort care and when anti-cancer care has stopped. And you can see here there's a lovely inpatient unit and the lovely gardens and, of course, the requisite water feature. But it's a mistake to think of hospice care only as a place, or that the innovations discovered here only apply to those that are near death. If you think about what was really learned in hospice care, it's about case management services and primarily nurse-based, and that it's a team approach to managing the patient's care and the patient as part of his or her family. I want to show you this data, which is very interesting. This is looking at a representative sample of all Americans who died in the US. And it looks at where they died, whether they were in home care, or in hospice care, and this is primarily hospice care at home, or in a nursing home, or in hospital care. And this is looking at 3 areas, 3 particular issues that family members reported. The patient wanted more pain relief, the patient wanted more physician contact, and the patient got no respect. Now, as you look at this data, one of the things that should strike you is here. Look at this hospital area. 50% of the family members said the patient wanted more physician contact. Well, if you were going to look for advice of where to find a doctor, wouldn't you say, well, you would go to the hospital? That's where doctors tend to be. So it is striking that patients in this environment felt like they needed more physician contact. If you notice, the got no respect and pain control issues were, and physician contact issues were all an issue in nursing homes. And if you notice, really the best outcomes here were in home hospice care. And in home hospice care, this is not an environment where there are lots of doctors. This should give you the message that these needs were being met in a way that were unmet in other parts of the healthcare system. And this is another part of that study looking at that statement of where was the overall best or where was overall excellent quality of care. And you should notice here again that in the hospice sector, outcomes were better. Well, if you were designing a healthcare system, or if you're advocating for someone you know and you love, wouldn't you want to make sure and find out what is it that is happening here and make sure it gets into these other areas of healthcare? That is precisely the focus of this talk